Introduce the next speaker, Professor Hamdy Abdelazim. Professor Hamdy Abdelazim is the famous professor of clinical oncology at Qasr Al Aini Clinical Oncology Department. I had also the privilege to practice with him over the past 30 years in the same department. He has been bringing hope all the time to the oncology field. Today he will bring new hope with immunotherapy. Please, Professor Hamdy.
Yeah, thank you so much, Dr. Hisham, for your kind introduction. And again, thank you, Hisham Al-Ghazali, for inviting me to this important conference. And thank you, Hisham, again, for fixing the weather. It is a beautiful weather this year. My topic is for immunotherapy in triple-negative breast cancer. And because it's a new approach in the treatment of breast cancer, we need to spend a few minutes on the basics of immunotherapy in general, and to see what we need to know about the tools the body has for immunotherapy. And the tools, actually, they are the immune cells when they go to the tumor microenvironment, which is the TILs, tumor-infiltrating lymphocytes. So in a way, cancer is a chronic immunological disease, if you wish, and it is characterized by immune activation related to tumor expressing certain tumor antigens, which are recognized as non-self by the host. So the immune system can survey tumors for their tumor antigens and can actually eliminate many early tumors. And the tools of the body to do so is to send their messenger, and the messenger is called tumor-infiltrating lymphocytes. So in a way, tumor-infiltrating lymphocytes, they are recruited by the immune system into the tumor microenvironment in an attempt to control the cancer growth. So if you wish to have a very simple definition of tumor-infiltrating lymphocytes, it is an existing immunity against the tumor. So whether this immunity will succeed or not, it depends on so many things, but we can see that the presence in triple-negative breast cancer of tumor-infiltrating lymphocytes in a high percentage in pink here is associated with a better prognosis compared to 0 TILs in red, which is associated with a poorer prognosis. So the quantity of tumor-infiltrating lymphocytes is crucial determinant of the outcome in triple-negative breast cancer. And by the way, we have plenty of studies like this. This is not the only one. And in particular, this study, for every 10% increase in the stromal TILs, there is an associated improvement in disease-free survival and overall survival. So in a way, you can quantitate the benefit. By gene expression profile, the group from Baylor, again, they could show that we have different types and subtypes of triple-negative breast cancer. What is important for me here is number 3 and 4. According to gene expression profile, you have basal-like immune suppressed and basal-like immune activated. And if you go to the survival of these patients, according to the publication, you can see that the immune activated in light blue has the best prognosis compared to the immune suppressed. So the immunity is doing something important in breast cancer. But we need to understand that not all the immune cells are competent enough to deal with cancer. On the contrary, we have some immune cells in our bodies that can promote rather than destroy the cancer cells. And we have seen that in this review, that the tumor-infiltrating lymphocytes, they can be tumor-suppressing cells, which we actually need to have. But in parallel, we have other components of tumor-infiltrating lymphocytes that they can really be tumor-promoting. Now you are in a hot soup if you have a mixture of this. We don't know which is taking the lead, the tumor-promoting or the tumor-suppressing TILs. In a subsequent work, we could see that the components of the TILs are very important, where if you have high cytotoxic T cell count, which is a good cell for cancer immunity, and low macrophage type 2, which is a bad cell for cancer immunity, then you have the best prognosis, and vice versa. If you have high number of M2 and low number of cytotoxic T cells. The bottom line is like this. T cells, cytotoxic T cells, they can control human breast cancer, no doubt about that. That's we have seen in several models. But the presence of immunosuppressive cells, that is the T regulatory cells, the M2, and so on, they can abrogate this action. So the immune microenvironment in breast cancer can be predictor for relapse-free survival and overall survival according to the components of this. So to sum up, in many cancers, tumor-infiltrating lymphocytes are recruited into the tumor microenvironment in an attempt to control the growth, because that's a foreign body for the immune system. Although TILs can promote tumor destruction via anti-tumor immune response, they still can promote the tumor progression. So both the quantity and the quality of TILs are crucial determinant for the prognosis in many cancer types, including triple-negative breast cancer. Marked infiltration by cytotoxic T cells, always remember this, that's the good cell for cancer immunity. That's always independent prognostic factor if it is high infiltration, while the high level of the bad cells, if you wish, T regulatory or M2 or T helper type 2, they will do the reverse. Among breast cancer, which is important for us today, subtypes, the quantity of TILs is consistently prognostic in triple-negative breast cancer. We have big evidence from many large trials. And TILs in other trials could show to predict the pathological complete remission to chemotherapy in triple-negative breast cancer. So we need to see what we can expect from anti-tumor immune response. As I mentioned before, cancer cells, they often display unusual proteins, which are tumor-associated antigens, which are recognized actually by the immune cells as non-self. It's the situation like in virus and bacterial infection. So the immune system is able to mount an active anti-tumor response like this. Look at this. That's the tumor. If the tumor can express a foreign antigen to my body, it will be uptaken by the antigen-presenting cells, and it will take the antigen to present to the T lymphocyte. Now the T lymphocyte is activated by the presence of this antigen. They will proliferate in the lymph node areas, and then after proliferation, they will go to attack the tumor. That's the TILs. That's the tumor microenvironment. So they can really do something for the tumor. They can induce tumor regression or eradication, or they can be just observers. They might not be able to do so. So cancer actually can defeat the host immune response by so many mechanisms, which is beyond the scope of today's meeting. But what I need to focus on is the immune checkpoint, because cancer cells can break the immune cycle that we have just seen by utilizing the so-called immune checkpoints. Let's see what we mean by immune checkpoints. Physiologically, our immune system is very highly regulated, such that if the immune system is activated, it should be shut down immediately after the antigen eradication function is done. So we are not allowed to keep activated T cells inside our body. That's why we need the immune checkpoints. And the immune checkpoints actually, they are, as the name implies, inhibitory pathways to downregulate the function of T cells once it is done with its effect. So the T cell is very peculiar in activation. It needs an antigen to be activated, which is in red here, but it needs another signal. So the antigen presented to the T cell for the T cell receptor is called signal 1. This is not enough to activate the T cell. The T cells will need 2. The second signal is again provided by the antigen presenting cells by a molecule called B7 and the receptor called CD28. Now the T cell is in full power. Then the T cell, it will do the job to eradicate the antigen, but at the same time, once the T cell is activated, an inhibitory mechanism will start to be built, because we need to stop the function of T cells after a while. That's physiologically speaking. So here we have this. You have, that is the second signal, and that is the first signal. And now the T cell is activated, fully activated by the two signals. Once the T cell is activated and it eradicated the antigen, we start to have another molecule, which is called CTL4 here, which will bind to B7, and this is a negative regulator of the T cell. So the T cell will be negatively regulated by the CTLA4. And importantly, this molecule will bind to the T cell with the B7 more strongly compared to the positive signal. So the T cell now is inhibited. The most famous way to inhibit the T cells is something else, is to inhibit the T cells after doing the job, and that's the function of a receptor called PD-1 receptor. The PD-1 is programmed cell death receptor, and as the name implies, it means that we have cell death for the T cells by this receptor. It has two ligands, PD-L1 and PD-L2, and once it is activated, the PD-1 receptor is activated, it will inhibit the T cell proliferation. So importantly, the cancer cell is very intelligent cell. It has this antigen, and once it has this antigen, the T cell will attack and will secrete interference to kill the cancer cells. However, the cancer cell will protect itself by expression of PD-L1, which will induce actually T cell suppression and T cell apoptosis. Now, the tumor microenvironment, it can have tumor-infiltrating lymphocytes, but the cancer cells could really defeat the tumor-infiltrating lymphocytes. Tumor cells, antigens, antigen-presenting cells, T cells activation, signal 1, signal 2. Now the T cells is fully active, attacking the tumor, tumor protecting itself by PD-L1 expression. Then the T cells will be inhibited at the tumor microenvironment, and that's what we call immunosuppression at the tumor microenvironment. So in order to restore the T cell function, that's the theme of immunotherapy, try to restore the T cell function at the site of the tumor microenvironment. And we can do so by so many ways. That's the tumor-infiltrating lymphocytes, how they evolve. Start with a T lymphocyte activated by an antigen in the lymph node, and if the CTL4 is present, the T cell will be inhibited. If you give a monoclonal antibody in red, you will activate the T cell once again, and now the T cell will go to the tumor site as tumor-infiltrating lymphocytes, but there they will be confronted by the PD-L1 expression by the tumor, so the tumor immunity will be inhibited, immunosuppressed microenvironment. If you give a monoclonal antibody here against PD-1 and PD-L1, you will block the inhibition of the T lymphocytes. Now the T lymphocytes at the tumor microenvironment will be activated. Okay, let's take this and go to the clinic and see how can we use the anti-PD-1 and anti-PD-L1 in the clinic, and how can we select our patients. Importantly, the patients who are going to respond to this kind of drugs, the anti-PD-1 should have expression of the bad molecule, which is PD-L1. So if you measure the PD-L1 by immunohistochemistry in lung cancer, like in this trial, you will find that they are expressed in mild or moderate or marked positivity of PD-L1 in the lung cancer specimen. And if you treat by anti-PD-1 in these patients, you will find that patients with very high expression in red of PD-L1, the biomarker, they respond very beautifully to a second line to anti-PD-1 therapy. And the progression-free survival and overall survival for this population is certainly higher than patients with weak expression of the target protein. In triple-negative breast cancer, we have so many reasons to think positively for this approach. To start with, the Cancer Genome Atlas has shown that significant greater expression of PD-L1 gene in triple-negative breast cancer compared to non-triple-negative breast cancer. So in essence, these tumors already, they can express the PD-L1 gene. So they are ready for your therapy. Breast cancer tissue microarray, another way of expression for the protein this time, could show that the expression of PD-L1 is present in around 20% of triple-negative breast cancer specimen. I'm sorry. Importantly, PD-L1 expression by tumor cells or tumor-infiltrating lymphocytes is seen in around 90% of triple-negative breast cancer specimens again. And these tumors are really equipped with higher infiltration with T-cell cytotoxic infiltrates. That's to say, the good cells are there, but they are inhibited. So the triple-negative breast cancer can be considered as a frank example of adaptive immune resistance in which T-cell-rich microenvironment is associated, is associated with immune inhibitory pathway that is the PD-L1. So that's enough reason for any clinical study developer to try PD-L1 and PD-1 inhibitors in this patient population. And actually, at the present time, we have plenty of ongoing trials and very few reports for the provisional data set. And the Keynote-012 utilized pembrolizumab in the treatment of triple-negative breast cancer as first, second, third, and fourth line. And they used a dose of 10 milligrams per kg every 2 weeks for this patient's population. And they mandated more than 1% of tumor cells to be positive for PD-L1 for inclusion in the study. And just to remind you, in lung cancer, the real responders were more than 50%. But that's where the study inclusion criteria anyway. They are heavily pretreated, the majority, and we have around 10% of brain metastasis coexisting. And the complete remission, partial remission, stable disease was seen in the range of 40% of the population. For me, that's a proof of concept. You needed this trial to know that a solo drug, anti-PD-1, the pembrolizumab, is effective in this population of patients. Although I think we need to do a lot to see how we can best select our patients to use these drugs. And you can see a spectrum of tumor regressions in this small cohort of patients. And what is important for me is that immunotherapy in triple-negative breast cancer is like immunotherapy in other areas of cancer, where you can see real long-term durable responses. Once the disease is going to respond, usually the response duration is quite durable. We have in the last San Antonio another trial using another experimental monoclonal antibody against PD-L1 this time, the Julian trial. And again, we could see that we have initial responses in triple-negative breast cancer, and this was better seen if you choose with PD-L1 positivity. The take-home message, we have extensive evidence to indicate that the checkpoint inhibitors targeting PD-1 or PD-L1 are active in so many huge number of tumor types. So this is a treatment that would change the practice in many cancer types. Triple-negative breast cancer has been associated with various characteristics in which immunotherapy with anti-PD-1 would be a rational therapy. First, they have higher tumor-infiltrating lymphocytes, which means an existing immunity against the tumor in the tumor microenvironment. Again, they have higher PD-L1 expression, which means that the tumor-infiltrating lymphocytes are paralyzed by the immunosuppressive molecules like PD-L1. So that is a very good rationale to use blockers of PD-1 or PD-L1 in the clinic. The initial data of pembrolizumab in triple-negative breast cancer is quite promising, but of course the challenge, how we best select the responding tumors, we need to work on validated biomarkers in this aspect. And thank you for your attention.